What you should know about lung cancer now. We're joined by Dr. Jaspel Singh. He's a professor of internal medicine and an associate dean for the faculty development at Wake Forest University School of Medicine. He's a nationally recognized leader in pulmonary and critical care, known for advancing AI, team-based care, and equity in healthcare. Dr. Singh has spoken for top medical organizations, consulted for leading industry groups, and has been featured across major media outlets. His work blends technical expertise with a human-centered approach to care. Ladies and gentlemen, Dr. Jaspel Singh.
All right, well, thanks for having me. I'm Jaspel Singh. I'm just going to sort of talk to you a little bit about lung cancer. Who remembers a guy named Rodney Dangerfield, a comedian? He always said one line. What was that? I got no respect. So lung cancer is kind of like the Rodney Dangerfields of cancer. It gets no respect. And I'll talk to you about why that is, and we'll kind of talk about how to get it. So we're going to give, first of all, thanks to the organizers. Look at this crowd. Look at these people. It's a lot of work put into this. So let's give a round of applause. All right. And I'm honored to be here amongst you all. And honestly, for my people, I'm kind of jealous you all have this, actually. I'm trying to get a forum like this started for my people as well, that they can have a forum to talk about their health issues with experts in front of them and ask them hard questions like that great clinical trial panel that we just had. Those are things we need to do. And that's why we're here. We're also here to talk today about myths and misunderstandings to inform you and then talk about what we can do together for everybody and give hope, because there's a lot of hope in lung cancer now that wasn't there when I trained. When I did my medical school training not too long ago in Chicago, actually, that's where I grew up, that's where I went to medical school. It was very different, and things are changing. So who thinks lung cancer is rare? Any breast cancer survivors here, brave ones? Any colon cancer survivors in here? Great. When we did this polling when I was a student of lung cancer, guess what? They didn't survive long because we found it late. We didn't have many treatment options, and there was a very different. Well, today, lung cancer is the #1 cancer killer for men and women. It kills more people in this country than colon, breast combined. You may not realize that. And it's also not necessarily all smokers. We'll get to that a little bit. This is not just a US problem, it's a global, worldwide problem. So we're seeing this all around the globe. That's why there's so much interest in lung cancer today. All right, we need to take it seriously. Another thing I hear from my patients a lot, and I do hear this a lot. I actually was working this morning at Carolina Medical Center down the street, so I got a little bit late. I didn't get to see the morning stuff. But a lot of my patients this morning said, you know what, doc, I don't feel like I had cancer. They don't feel like it. Why is that? Well, we'll talk about that a little bit. Part of it is that little dot right there you see? That's the lung cancer. It's stuck in the lungs, which is just taking a very small amount of space. But that thing can spread. And that's where we don't realize, we don't feel those little tiny spots in the center of our lungs. We just don't, we may have symptoms like cough, maybe coughing up some blood, some shortness of breath. We may lose appetite, get some chest pain, some hoarseness, some weight loss, all these things. But those are often later when it's more advanced. So get checked out, and this is why it's important. Myth, only smokers get lung cancer. And we hear that a lot, right? This is my patient, actually. This is permission obtained. I held a lung cancer summit, not on national experts, last week at Advocate Health down the street here. And a lot of our lung cancers now are in never smokers or those who have quit a while ago. So this is Marvin, my friend here, who retired here. Marvin's very educated, very well off, never smoked, and he's battling for his life. And he says for you all to pray for him, because he was able to come to our summit, but we were worried that there was too many people here for risk for exposure while he's on chemo. So he's on chemo right now, and you can see, you know, I said, Marvin, can you be a panelist for one of my sessions? He said, sure, but can you ask me one thing? How did I get this disease? I said, Marvin, I don't know. I just don't. I have no idea how you got this. And it's not fair, right? Truth is, you got lungs, you can have lung cancer. You know, and that's the reality. And we're seeing more of this scary disease coming up amongst us, in front of us. Other risk factors, another non-smoker at my same summit, This gentleman's he's tough as nails. He's a firefighter who retired and now trains more firefighters and was just not feeling so great, like I'm short of breath. The guy had a whole lung full of cancer cells. Fluid filled up an entire lung. Now that was a few years ago. How good does he look now? Right? The treatments have advanced a lot. And we're going to talk a little about that there's hope now. It's very different. But we're learning that non-smokers, there's genetics, there's things we can't hide from, like getting older. That's a risk factor. Radon. So we grew up in Chicago. A lot of people have basements in Chicago, not so much in the South here for the soil reasons, right? But a lot of basements have radon and stuff like that. You'll see that's a number one environmental cause of lung cancer. So if you think you might have high radon, get your basement checked, for example, or get your house checked. Secondhand smoke, air pollution, right? There's occupational exposures. Some people who work in certain dusty environments, for example. Asbestos, you may have heard about. Diesel exhaust, indoor pollutants around the world. I'm from India, and a lot of people from India get lung cancer because they cook with wooden stoves. And so you'll see stuff like that happening around the globe. So I love this one. Fill in the blank. I did my internet search on lung cancer, doc, and I found what? What'd you find? Well, you got lung cancer, and guess what? I'm going to die. No, wait, let's stop up. Oh, I found out I think I got lung cancer, and oh, by the way, I found this thing I can inhale or take or a pill, and it'll cure it. And I hear that a lot, right? So the key is that we have a whole team. The key is the internet's not going to cure you, right? We're going to have some options. We're going to go through them. There's lots of reasons for hope. There was this ad for this car company called Oldsmobile. Who remembers those Oldsmobiles? And the ad was not your father's Oldsmobile. Not a great ad because it kind of probably did him in, but it actually was a very important message that things have changed. Technology is changing. We're going to advance in prevention, detection. We're going to find it earlier. I do some pretty cool stuff. I have students with me all the time, and we do robotic bronchoscopies. There's all kinds of cool stuff happening in the surgery world, the radiation world. The chemotherapy is not like it used to be, right? All these things have changed. And we're going to talk a little bit about that. And we're going to talk about not about lung cancer in general, but for Black Americans. What does it look like today? Well, we have some problems, right? All these advancements, we haven't done as well with Black populations. We want to talk about prevention, diagnosis, and treatment. Let's talk about smoking cessation. I know as we talk about lung cancer, I want to talk about the cancer, but the most important way to treat cancer is to prevent in the first place, right? Lower your odds. Now, we can't control the future. We're not, our creator. We don't have those powers. We're kind of going to lower the odds, right? To lower the odds, basically cut down smoking. Well, it turns out that actually, and I'm not trying to generalize here, I'm just trying to give you some general historical patterns that have been noted. One of the issues we've had with African-American populations is that menthol cigarettes are favored, right? Flavoring. Well, that sounds great, except it's also harder to quit, right? And it's a little bit more addictive. So things like that. African-Americans tend to smoke less and smoke later. So they don't have the same sort of smoking exposure. The dosing is different versus white counterparts in general, right? Obviously, this is just generalism. It's not true for every single person. And then sort of the idea of like counseling for smoking. How many of you go to your doctor have heard a doctor say you ought to quit smoking? Some do, but they don't give you full counseling. They don't give you all the supplements, the nicotine, the patches, the full shebang. And so you may not get full access to all that. There's also health literacy issues. There's the fact that a lot of African Americans live in rural communities. There's insurance issues and coverage there. Access to a primary care doctor. How many of you have primary care doctors? How many are looking for one? How many have trouble finding one? How many have trouble finding one you trust? Right? And so all those things come into that play, right? And so these are hard, right? You don't have that trust. You don't have the relationships. You can't get a hold of them when you need them. And all those kinds of things. I have the same issues. I'm in the system, and I have issues, right? So the quit rates are lower for African Americans, no surprise. All right, let's talk about smoking cessation. We got some work to do. Let's talk about low-dose CT scanning. Anyone know what a low-dose CT is? So it's actually interesting. People look at this for years, is that the idea, if you could do a CT scan on someone every year who's at a higher risk of lung cancer, you'll find spots like my friend did here, and that right upper lobe. You see that little spot right there? I don't know if you can see it. Right there. You see that? That's an early lung cancer. The only way we knew is sometimes you can just find it by what we call, it wasn't there last year. but now it's here. Oh boy, now we're worried. Now, if we scanned everybody, we'd find spots in all of you. I'm from the Midwest, so a lot of people in the Midwest have infections that make a scar. So we don't scan everybody, but we scan people that are high risk, smokers, and ideally, and we'll talk about who Medicare allows us to do for this right now. But we find this early. Guess what? It's very treatable and very curable. So we try to find these things early before they have symptoms, before they have shortness of breath, before they're coughing, before they're having a loss of weight. So it's basically a CT scan and they say low dose because it's less radiation than it used to be. It used to be like these things get a lot of radiation on them. They're much lower now and lots of great images. And you get the image analysis and the computer looks at the images, the radiologist looks at the images, and we sort of call and sort of see what's going on. We also have, anyone have a CT scan for your heart before? Nowadays, a lot of people are having heart CT scans. I want to get one because it's actually, I'm actually going to talk to my doctor about it next month. It's about just checking if I have heart disease with a CT scan. Well, they check the heart. Guess what else is in the same field? The lungs. And you'll sometimes find a spot there. We call that incidentally found, right? We just, whoa, we didn't expect it to be there, now it's there. Because we're getting more scans for a lot of reasons. We're finding more of these spots. And so my friend, Dr. Doty here, and his friend Lisa, they've been running this program called the Insulin Lung Nodule Program, where you basically try to find people and then you basically say, you know what, Mr. Smith, you had a spot on your lung. Did you know that? You know, the hospital mentioned that or somebody mentioned that. I didn't know what they were talking about. Well, come see us. We're going to talk to you about it. So we have a whole program behind the scenes that we've, Advocate Health, we've invested in to help people through that. Now, Mr. Smith be like, I don't know you. I don't know who you are. No thanks, right? And there is some of that, the mistrust of the system, right? We kind of heard about that probably a little bit last session, is that he's like, what are you talking about? This is what we're trying to create, but you can already imagine there are some issues here of us kind of rolling this program out. So we're working through it. Let's get back to lung cancer screening. So who's eligible? You have to be aged 50 to 80, and this is all on the Lung Cancer Initiative website, actually. They have a great site. They're the ones who brought me here today, so thanks to them. But on their website, they have a very nice website that tells you who's eligible. Age 50 to 80, you have to have a 20-pack year smoking history. You have to have either currently smoking or quit within the last 15 years. And no severe health problems that make it hard for you to have treatment. Now, they have something interesting with lung cancer. How many women get your mammograms every year? How many get your pap smears periodically or have had them? I'm so sorry about that. My wife's a primary care doctor who does pap smears, and I just, no thanks. It's just one of those things. They did something interesting with lung cancer. They said, you can't just order a CT, doc. You have to do shared decision making. Anyone know what that means? It means that you have to have formal counseling that, you know, Mr. Smith or Mrs. Smith, I'm going to recommend a lung cancer screen, lung CT for you. And normally I would just write the order or put the order in the computer. They said, no. We need you to talk to Mrs. Smith about basically what's the pros of doing it? What's the cons of doing it? By the way, if you have a spot in the lung, we got to go chase it. And you got to know that might be a lot of testing. It might be costly. You got to know about that. Sounds like a good idea, right? To have some more informed decision making, to get more buy-in. It sounds logical. But what's the hazard of that? Yeah, she won't do it. She's like, hell, you said that scared the hell out of me, right? Like, I don't want to do it anymore, right? And there's a problem with that. And I think we're wrestling with how to have that discussion. So shared decision-making is required for lung cancer screening, has to be documented. It's not required for men to have their PSA checked, which is, it's not required for colon cancer screening, it's not required for anything else, but it is required for lung cancer screening, which already puts lung cancer screening for CT scanning behind the 8 ball, right? It makes it harder. But we're working through it, so just watch out for that. All right, let's talk about lung cancer diagnosis and treatment. This is a map, basically, of density of lung cancer, how often it's found, and how many people die of it. Where are we? Not in the safe area, right? Right? So we're affected quite a bit. Now, black patients often get lung cancer at an earlier age, less likely to receive screening from the CT scans, less likely to, even if we test them, we call mutations, looking for personalized therapies, things that are more really cutting edge. Less likely to be offered surgery. Surgery is not cutting edge. It's just standard of care. And we're finding that in some communities, actually, they're not getting a fair shake of getting offered surgery. Or they don't want it. They sort of say, oh, I don't really want it. I don't trust a surgeon cutting on me. You kind of hear that a lot. They're less likely to be offered higher cost treatments. It's one thing that they say they don't want it. They may not even be offered it. And that's a problem, right? So we're kind of working through that, trying to hold people to the ground a little bit about this. All right, many barriers. I'm not going to sort of go into too much detail, but basically rural communities. Many African Americans live in rural communities, right? And it's a higher incidence there. Higher mortality when you're in the rural area. Radon exposure, because guess what? A lot of us, I grew up, my parents grew up very poor, and I had a lot of African American friends, and we all had basement homes that were small, that were poor, they're not well constructed, and they end up having high radon and other issues. So watch out for that. Access to care, we kind of talked about a little bit, but the biggest one I get is the nihilism. People are like, you know what, I got cancer, doc, don't do anything. Or you know what, I don't trust the system. Or you know what, I don't want to tell anybody because guess what, I smoked and I deserve it. Right? That's unfortunately a common self-perception, that is. Or it might be expensive. Or who are these people calling me? Who are these people kind of working on me? They get a spot in their lung and they show up with me in their office. It's like, oh, man, I'm screwed now, right? I got a guy with a turban in my office. Who is this guy? Right? And you want to tell me you want to do some kind of robot to my lung and all this other stuff? They're already kind of like, no way, no thank you. These are things that we see. And then I'm not going to talk about all the barriers, but there's a lot of them. So we're trying to address them, and at Living Cancer Institute, we even have a mobile screening bus. We're trying to go to the communities that have high incidence. And it sounds like a great idea. We've tried education videos, we tried public awareness events, we tried things like this. We're trying to expand what we call telehealth coverage. But there's a lot of, this is a very complex endeavor. And the last session, someone asked, someone said a question, said, we need the clinical trial people to be more passionate. We're passionate, but we can't do it alone. We need your help. We need you to start talking about it and bringing this up to everybody because there's not enough people and not enough efforts here. Our lung bus, for example, is grant funded, and the grant funding dries up. What happens? That bus doesn't go, right? All these things are out there. We're trying our best. Mobile screening buses are great. This is our research fund, which I have some research projects myself going on. We always are looking for donors. If you're interested in that, just come see me. We're always looking for additional funding because this stuff is important. And we're trying to get it out to the communities. Myth, research will continue to advance to take care of me. I think it will. Technology will advance, except we've been sucker punched. That bottom graphic will be a sucker punch by the current administration in terms of research dollars. Some of you have heard about that. Basically, the carpet got pulled out of many of my colleagues around the country who are trying to do research in this space. They basically got the rug pulled under them, and some of them actually, the most experienced talent is going abroad. Because they're like, you know what, we can't do this, right? We're at the stage of our careers, they want us somewhere else, or they want us in industry. We're not gonna keep doing research because we can't. So I encourage you to consider research and that clinical trial thing I can't say enough about. We need more blacks in research trials because we need to understand what's happening. To be honest with you, I'm in the same talk with my own community. Immigrants, many of them are afraid of how ICE perceives them, stuff like that. They don't want to do clinical trials because it puts them on the radar. Right? These are things that we're seeing around the country with the current administration, but research is really suffering right now. Bring us the other myth, nothing we can do. This sounds hopeless. You're a depressing guy, Singh. And I say, you know what? No. There's a lot of reasons for hope. First of all, we're talking about lung cancer, right? We have new methods of smoking cessation, all these new treatments that are out there now. We have screening options now for those who are eligible. We can actually have great treatment options. I do something really cool downtown. I do one of the highest volume, what we call robotic bronchoscopies in the country to help detect early lung cancer with precision and safety. All right, it's one of those things that we're seeing a lot of really cool things. You're fortunate that in Charlotte, for those from the Charlotte community here, we have phenomenal resources. But then also, we also are starting to realize that, you know what, there's other ways to take care of your lungs, to take care of your health. It's not just, we're starting to realize that there's a link between diet, exercise, good, healthy sleep habits, emotional and psychological health, and that those who take care of their health are less likely to get lung cancer. We also know that there's ways to actually test for radon now. We also know to improve ventilation in kitchens and other higher risk areas. We also have protective gear now for those who need protection. Like many firefighters, for example, now have more protective gear. It's easier for those who don't know, firefighters out west or those who are fighting big forest fires, they oftentimes don't have any protection because there's not funded for them. We're trying to work with them, with their organizations to help them with that. But we also need you to help us advocate for clean air policies and where people are trying to do that. And then also, of course, watch out for smoking and all that stuff. I was debating, should I bring up vaccinations? That's a kind of a hot button for many people, right? But for those who are eligible, really consider vaccinations for things that you might be at risk for. And if you don't get vaccinated, be cautious, right? Because things are out there. And I lost my dad to COVID, right, in the early phase of the pandemic. And I saw a man who basically, he immigrated to Chicago when we were young. We grew up there. He worked 3 jobs and was fierce. And he was left as a very shriveled, debilitated gentleman by the time he died. And I saw firsthand, I was in the front line of the ICU working, when I signed more death certificates in 2020 in my 1 year than my entire career combined. And I'm worried about pandemics and things like that. So if you have questions about that, come talk to me. But I'm going to tell you that I'm a believer in the power of vaccinations, in minimizing your risk. All right. Lastly, I'm going to say one last thing. It's another call for more scientists. Last week we held. Who knew that Charlotte has the first medical school developed since the pandemic? Isn't that pretty cool? And it's a very modern facility. I get to teach there. That's me teaching in the corner there, in the left. And I'm addressing. We had a couple of predominantly black high school students, black high schools and elementary kids come and talk to us about career development, trying to encourage them to have science and math careers, because we need more in that space. We need more of you all actually in the pipeline for our great city. We also had what we call a mobile cart for them to learn how to do surgeries robotically, bring in new technology, and inspire the next generation, because we need more. That's my team on the left there. That's where we're doing our robotic bronchoscopies. And on the right there is some of the faculty from the summit I hosted last week, because we want to bring the best experts to Charlotte as possible. And if you have any questions, my email address is up there. I'm also on LinkedIn, probably way too much more than I need to be. But if you have any questions, I'm around here. Again, a round of applause for the organizers. You guys have done a phenomenal job. And let's win this fight against lung cancer, right? Let's do it. Thank you. Of course, let's take some questions.
If you had sarcoidosis, what precautions would you take?
Yeah, sarcoidosis is a strange disorder. It's like we don't think it's a cancer, it's just a lymph node inflammation. I'm not sure any precautions are needed in some cases. Some patients with sarcoidosis, though, are on medication to suppress their immune system. And so if you're on those medications, just be cautious of those. Cautious of additional infections and get regular screenings. Great question. Other questions?
I have a question. Let's say if you were a soldier and you were in Kandahar, Jalalabad, for over, let's say, 3-year period of time, back and forth with the Pupan and the situations that we had there. Do you think over time that your lungs do clear up, or do you think it's symptoms that stay within you? You know, we hear all kinds of stories of soldiers coming back, and yeah, we get compensated for it, but if you didn't smoke, drink, or get high or do the stuff, but yet you are there all the time, do you think that affect your mental state and your nervous system from just the exposures that I would have had there for
So there was a little bit of
3 years?
Yeah, a little bit of an echo. I think I heard the question that if you're stationed abroad and serving abroad, would the exposures there potentially put you at risk for other things in nervous system? Is that right? For your lungs? Okay. No, first of all, thank you for your service. Yeah, that's a great question, and thank you for your service again. But I would say we don't know. You know, abroad, all the dust, all the environmental stuff, we don't have enough scientific research to know for sure. I will say that that dust in general usually are not terribly harmful as long as you take some precautions. But we just don't know how the other exposures or what chemicals might have been in the environment. We just don't know. But I would say just do yourself, get checked up regularly, do your regular precautions, talk to your doctor, and we just can do your best. But thank you. Last question?
Yes, hi, I'm Celeste Hart. I work for Black newspapers. So when you talk about smoking, is this just cigarette smoking or are you talking about marijuana smoking too? Because all this about weed now, okay, especially
Yeah.
here in North Carolina.
Yeah, so great question about smoking. I was trying to figure out how much I want to go down this rabbit hole. So smoking, smoking, essentially, cigarettes have by far, we have tons of data on about how harmful they are. But now comes a question of things like cannabis, right, like weed, and also vaping, right? Vaping, there's some concerns about the vaping in our industry, in our research. The thing is, some of the research got cut off, as I mentioned earlier. The companies did sort of back down from some of the chemicals that were in there at one point, but a lot of us have a lot of concerns about them. The oils that are in there, the things that make it work, the additives for flavoring, all those things, we have some concerns because it goes directly to your lungs, and the lungs don't have a lot of protection inside them because the lining of the lungs is super thin. Like imagine like fine tissue paper, and so you're directly going from there to the tissue paper to the bloodstream. So a lot of us, we just don't have enough data and long-term studies on this, and so we have to kind of figure that out. My kids ask me, and they already know that I feel very strongly that I counsel my kids, my wife does too, to not do any kind of vaping or anything like that. Cannabis, right now, a lot of people are smoking weed and they think it's like healthy and they've been selling it as a health craze. A lot of us have concerns. I'll be honest with you, I'm not a fan of this, of how much it's just becoming like extremely common. I think in certain indications for pain control and things like that are unique, it can be helpful in unique situations. But I think the way we're consuming cannabis products may come back to haunt us. So just be careful. It's just like anything else, be balanced. And I think we don't take enough effort to work on things like diet, exercise, sleep, mental health, all those aspects. Those are, to me, are much more important right now in terms of balancing my health than everything else. See your doctor, take your medications, and follow through.
Yes, my question is about data centers. They're building a lot of data centers, and they're emitting something. Has research been done on the
No,
effect of that?
it's a great question about data centers. We're talking about my colleague actually at the hospital today about this. Like we're hearing a lot, especially small communities, rural communities where they're building these massive centers, some with so much power and pollution that they're building their own nuclear plants and they're building their own waste systems, which who knows where that waste is going, right? I don't know. Again, I'm sort of a corporation nihilist, right? I'm not sure the big corporations really are watching the health of the public. I don't know. I would just say that we need advocates. We need people to have those questions, have those dialogues, and we need more scientific research. Again, comes back to the science. We need science to help us answer these important questions. Now, we need data centers too, because of how we're consuming data these days, right? All of us are using AI in some ways. I see some cell phones here answering some important questions, looking things up right now. You're all using some data. I do it all the time as well. So we need those. We just have to balance it.
One more question. Like for kids, what's your statistics and things on kids getting lung cancer, and also like kids that are in environments that's just always, everybody smokes there, smoke is in their clothes, they smoke, they get it, they're in the environment, so they're inhaling it their whole life. Do you guys have any statistics on that, or what?
No, I think I just don't know. I mean, I'll be honest with you. When we immigrated to this country, I remember my neighbor downstairs in our little duplex, their kids all smoked, and my friend was 5. Started smoking at age 5. I thought, wow, right? And so this was just the culture in many places, right? The kids start young. So I don't know. I mean, obviously, hopefully we're seeing less of that now. We are seeing a drop in smoking in some youth. We're seeing a massive rise, though, in vaping. That's what we're seeing. That's what I think has us really concerned right now. So obviously, those kids would qualify for lung cancer screening. Encourage them, if you have family members that are in that situation, community members that people in your church or your communities that are high risk, encourage them to get a low-dose CT scan of the chest if they're at risk. All right? Thank you all.